Welcome back to the Deep Dive, where we take complex, high-stakes source material and turn it into actionable, crystal-clear knowledge.
Hello.
Our mission today is absolutely critical, especially for those of you preparing for your advanced MD anesthesia examinations. We are performing what amounts to a surgical deep dive into the pharmacology, clinical uses, and risks of the drug that, well, it really defines modern anesthesia, Propofol.
That is the perfect framing. For any aspiring specialist in anesthesia, Propofol is not merely a common tool, it is the cornerstone of contemporary practice.
Right.
And we are going beyond just rote memorization. Your examiners, they demand a critical understanding of its unique pharmacokinetics and, more importantly, the potential pitfalls inherent in its formulation and infusion profile.
So we've structured this entire deep dive to mimic precisely how you should organize and deliver, say, a top-tier, comprehensive 20-mark long answer question. Our sources today, the foundational textbooks and the most recent clinical reviews, provide all that necessary granular detail. This deep dive is designed to ensure you don't just know what Propofol does, but why it does it, and what that truly means when you are managing a crashing patient.
Yes. Let's get into it.
Let's unpack this essential anesthetic, focusing on the integrated details that truly differentiate an informed clinician from a basic student.
Okay, so to start strong in any exam answer, we must provide an immediate and accurate definition.
Okay.
Chemically, Propofol is a substituted stable phenolic compound, specifically is known as 2,6-D-isopropylphenol.
And a key point here, especially when comparing it to older induction agents, is that it's a non-chiral compound, right?
That's a crucial point of differentiation, yes.
Yeah.
It exists as a single stereoisomer, which simplifies its pharmacology quite a bit compared to, racemic mixtures.
And that chemical definition leads directly to its classification, an intravenous general anesthetic and sedative agent. But the profound reason it dominates the operating room is its utility.
Absolutely. It's globally the most commonly used induction agent, certainly in high-resource settings like the UK and USA.
And it's the agent that made total intravenous anesthesia TIVA not just feasible, but a highly refined practice.
And the clinical killer app of Propofol is really the quality of emergence. It offers a smooth, rapid induction and, vitally, the clear head recovery it provides.
I think we've all seen that. Unlike older agents that leave patients groggy or suffering from a prolonged hangover, Propofol facilitates a crisp, predictable wake-up.
That quality alone elevates it as the preferred drug in daycare or ambulatory surgery, where, fast turnover and high patient satisfaction are the primary goals.
Given its importance, how should a learner preparing for a high-stakes university exam expect to be tested on Propofol?
Right. You must prepare for it to appear in 3 formats, and you need to master all of them.
Okay, what are they?
First, the long answer, or LA, typically 20 marks. This demands the comprehensive structured review we're covering today. Chemistry, mechanism, PK, PD, uses, complications, and comparisons. You need depth and structure.
And the second?
Second, short notes, usually for 5 to 10 marks. These focus on highly specific, high-yield topics where precision is paramount. Things like Propofol infusion syndrome or PIS.
Right.
Or the specifics of its context-sensitive halftime, its CSHT, or its specialized role in neural anesthesia.
And then there's the VIVA, which is the rapid-fire knowledge check. The examiner wants to see if you possess instant access to the core facts.
Exactly. The VIVA requires you to know, without hesitation, what are the 4 ingredients in the standard emulsion? Why is its clearance faster than its elimination half-life suggests? What is the specific anti-emetic mechanism?
So if you can articulate those crucial facts instantly, you signal a comprehensive and safe level of understanding.
That is the integrated knowledge we are aiming to establish here.
Okay, let's move from the clinical application to the inherent chemistry, because in the case of Propofol, the formulation is the root of many of its biggest problems, and it necessitates our careful handling protocols.
Correct. As we established, Propofol is 2,6-D-isopropylphenol, and because of the high number of lipophilic isopropyl groups attached to that phenol ring, it is extremely lipid-soluble. It has a log P value of 3.6, but it is almost entirely insoluble in water.
Which is why we get that instantly recognizable milky white solution. This means you have to use a lipid vehicle forming an isotonic oil and water emulsion. And for any exam, the precise contents of this standard emulsion are absolutely mandatory knowledge.
You must be able to list all 4 components. The standard emulsion, whether it's the original Diprovan or a generic preparation, contains 1% Propofol,
The active ingredient.
0.1% soybean oil, which is the lipid vehicle, 2.25% glycerol, which is added to maintain isotonicity, and 1.2% pure purified egg phosphatide.
And that last one acts as the emulsifier, stabilizing the microscopic oil droplets, and it's derived from egg yolk.
Yes,
That egg phosphatide always leads to a common exam trap regarding patient allergies.
it does. And it's crucial to understand the distinction. Most clinically significant egg allergies are directed against the protein found in the egg white, or albumin. The emulsifier, phosphatidylcholine, is extracted from the yolk, or lecithin.
So, a general egg allergy isn't an absolute no-go for propofol.
A documented history of general egg allergy is not usually an absolute contraindication for propofol administration, though extreme vigilance is always warranted. This nuanced understanding really impresses an examiner.
Okay, moving on, we need to address preservatives. This is a big distinction between the original and generic preparations, isn't it?
It is. Historically, there was a difference in pH and preservative choice. Generic preparations often have a lower, more acidic pH ranging from 4.5 to 6.5, and they typically rely on sodium metabisulfite as their antimicrobial preservative.
And the original Diprivon.
The original formulation, Diprivon, tends to have a slightly higher near-physiologic pH, maybe 7 to 8.5, and it uses disodium edetate or EDTA, sometimes adjusted with sodium hydroxide.
And the whole point of these preservatives is containment, because that 10% lipid emulsion is, frankly, an outstanding and rich culture medium.
It's a perfect petri dish. It's capable of supporting the rapid growth of bacteria like Staphylococcus aureus or E. coli.
Exactly. This brings us directly to the three major clinical implications of this unique formulation, which demand dedicated attention in an exam.
Let's start with the most common one.
The first and most common is pain on injection. I still remember my first experience. It felt like fire starting in the vein.
It's the most frequent adverse event, reported in over 60% of patients without pretreatment. The pain is caused by two factors: the chemical irritation from the lipid vehicle itself, and often in the generic lower pH formulations, the irritation caused by that lower pH.
So we have to know the mitigation methods.
Mitigation is crucial. You always want to use a large high-flow vein like the antecubital fossa and avoid the smaller, more sensitive veins on the dorsum of the hand.
And pretreatment is the clinical standard. You can administer 1% lidocaine prior to the injection or mix it directly with the propofol solution.
And when you discuss mixing with lidocaine in the exam, you must include the caveat.
What's that?
Adding an agent like lidocaine, which is a cationic drug, can risk destabilizing the emulsion. It causes an immediate fall in the zeta potential or the electrostatic charge, which can lead to the coalescence of the oil droplets.
And if those larger droplets get administered, you're looking at a risk of pulmonary embolism.
A serious risk.
Yeah.
Therefore, if you mix it, the source material stresses it must be administered immediately within minutes. Alternative approaches include using MC-TLCT formulations or the 2% propofol formulations, which are designed to reduce injection pain.
Okay. The second and far more dangerous implication is bacterial contamination. The sources really emphasize this as a major public safety issue.
This is a matter of patient safety that has resulted in documented sepsis outbreaks and fatalities. Because the lipid emulsion is such a potent culture medium, strict aseptic technique is non-negotiable every single time you handle propofol.
And this is a Viva favorite. An open ampule must be used or discarded within
6 hours.
6 hours. The sterility cannot be guaranteed past that time, and this regulation is absolute in all practice settings.
Absolutely.
Finally, what about the shelf life of the intact vial?
The intact vials are stable at room temperature and are not light sensitive, which is convenient for storage. This stability is largely due to the preservative system, but once you breach that seal, that 6-hour clock starts ticking.
Before we leave formulation, what about the modern alternative Fospropofol?
Right. Fospropofol, which was marketed as Aquavan, represents an attempt to entirely bypass the lipid emulsion complications. It's a water-soluble prodrug.
So it's inactive until metabolized.
Exactly. The propofol molecule is phosphorylated, making it soluble. The active propofol is then liberated in vivo after hydrolysis by the enzyme alkaline phosphatases, which are widely distributed throughout the body.
So it avoids the pain on injection, the contamination risk, and the hypertriglyceridemia, which sounds perfect. What's the clinical trade-off?
The trade-off is speed. Because the drug liberation depends on enzymatic hydrolysis, fospropofol has a significantly slower onset and a longer time to peak effect than direct-acting propofol.
So not great for a rapid induction.
It limits its utility there, yes. Furthermore, a common side effect is mild to moderate perineal paresthesias or pruritus, which is believed to be due to the phosphate metabolite byproduct of the hydrolysis.
That's a great comparative point for the exam. Lipid emulsion causes pain on injection. The water-soluble prodrug causes paresthesia on injection.
Moving from the bottle to the brain, let's establish the mechanism of action. This must be the centerpiece of the MOA section in your long answer.
Okay, so the mandatory starting point is the effect on GABA receptors.
Precisely. Propofol is a highly selective modulator, primarily binding to the beta subunit of the GABA receptor, although the alpha and gamma-2 subunits also play a role in the modulation. This binding is essential for its hypnotic effect.
And what is the downstream result of that binding?
Propofol acts allosterically to enhance the action of the major inhibitory neurotransmitter, GABA. It doesn't replace GABA, it potentiates it.
Right.
This mechanism shifts the concentration response curve to the left, which means the receptor is far more sensitive to the naturally available GABA. Physiologically, propofol decreases the rate of dissociation of GABA from its receptor.
Which significantly increases the duration of the chloride channel opening.
Yes.
And that increased chloride influx means hyperpolarization, functional inhibition of the postsynaptic neuron, and clinically sedation and hypnosis.
That's the core mechanism. You must also distinguish between its effects based on clinical concentration. The indirect effect potentiating existing GABA occurs at low clinical concentrations, so the typical sedative and induction range. However, at high, often superclinical concentrations, propofol exhibits a direct effect, acting as an agonist itself, capable of opening the chloride channel even in the complete absence of GABA. This distinction is important for understanding its wide dose-response curve.
We also know propofol has secondary actions that contribute to its versatility. What else is going on in the CNS?
Well, propofol also inhibits the NMDA subtype of the glutamate receptor, which is the primary excitatory pathway.
And that action is crucial for attenuating excitotoxicity, and it's thought to contribute significantly to its neuroprotective qualities, doesn't it?
It does, linking it to the older barbiturates like Thiopentone. It also potentiates glycine receptors, particularly those found in the spinal cord.
So let's connect the mechanism to the clinical effects. GABA agonism leads to hypnosis. What about the secondary mechanisms?
The depression of spinal cord activity, mediated partly through that potentiation of glycine receptors, explains its useful antipruritic effects.
And that's a high-yield point, as propofol is often used in subhypnotic doses to treat spinal opioid-induced pruritus.
Yes, exactly. Furthermore, the inhibition of glutamate-mediated excitotoxicity via NMDA receptor modulation strongly supports its use for cerebral protection during focal ischemia, providing a neuroprotective effect comparable to thiopentone.
So a strong MOA section integrates all three receptors, GABA, NMDA, and glycine, and ties those effects directly to the core clinical benefits: hypnosis, neuroprotection, and antipruritus.
Precisely. Now we arrive at the most crucial section for the long answer: pharmacokinetics, or PK. Propofol's PK profile is truly revolutionary and explains why it dominates Tyvia.
Okay, standard PK dictates 100% bioavailability since it's IV only, high lipid solubility, and high protein binding at around 98%. The rapid onset is pretty standard for a lipophilic agent.
Yes, the rapid onset is due to high distribution to vessel-rich tissues, particularly the brain. The initial distribution half-life is remarkably short, typically 2 to 8 minutes.
But the truly revolutionary aspect is the speed of recovery, right?
That's it. Awakening after a single bolus is rapid, primarily because the drug is rapidly redistributed out of the central compartment, the brain, into peripheral, less perfused tissues. This rapid redistribution ensures a swift drop in central drug concentration.
Okay, let's talk about metabolism and elimination. This is where propofol's clearance data is truly exceptional, and the examiner will definitely focus here.
You must state this fact clearly. Propofol clearance is extremely high. We're talking between 1.5 and 2.2 liters per minute, or approximately 30 to 60 milliliter per minute per kilogram.
That value is so high that it often exceeds hepatic blood flow itself.
Yes.
Wait, clearance exceeds hepatic blood flow. That is counterintuitive for a drug that's metabolized by the liver. What does that truly imply for the learner?
It implies that the liver, while the primary site, is not the only site of metabolism, and its capacity is fully utilized and often surpassed. We have to account for significant extra-hepatic metabolism.
So even though the primary metabolism is rapid hepatic conjugation to inactive metabolites, a substantial amount of the drug is cleared elsewhere. So where are these key extra-hepatic sites located?
The lungs contribute significantly. Sources indicate that the lungs are responsible for approximately 30% first-pass uptake and elimination immediately following a bolus dose. Metabolism also occurs in the kidneys and potentially the brain, both of which contain the necessary enzymes.
This extrahepatic pathway is the clinical advantage, isn't it? It's the reason for its reliability.
It is. Because multiple organs contribute, propofol clearance is reliably unaffected by severe renal or hepatic disease. This makes it the agent of choice for induction and maintenance in complex patient populations where liver or kidney function may be compromised.
And that's a huge differentiating factor from many older cumulative agents.
A huge factor.
This high non-cumulative clearance directly brings us to the second high-yield concept, context-sensitive half-time, or CSHT. Can you define that precisely for us?
The CSHT is the time required for the plasma concentration of the drug to fall by 50% after stopping a continuous infusion of a specified duration. That duration is the context. This metric is a true indicator of cumulative potential.
And how does propofol score?
Exceptionally well. Propofol's CSHT is remarkably short. It's approximately 20 minutes after a 2-hour infusion, and critically remains less than 40 minutes even for infusions lasting up to 8 hours.
So even if I run a TVIS infusion for a long case, I can still expect the patient to wake up predictably and quickly, usually within the half-hour range. That's the real takeaway for the OR.
Absolutely. Even though propofol has a long terminal elimination half-life up to 23 hours, the rapid clearance prevents accumulation from significantly prolonging the wake-up time in standard duration surgery.
Right, so we see a flat CSHT curve when compared to a steeply rising curve for agents like Thiopentone or fentanyl,
Which clearly demonstrates its non-cumulative nature.
In summary, this rapid clearance ensures a rapid, predictable, and clear-headed recovery with minimal hangover, cementing its dominance in modern TIBA practice.
Now we shift to pharmacodynamics, what the drug does to the body. And we have to start with the system that presents the most acute clinical challenge, the cardiovascular system.
The primary cardiorespiratory effect and the cause of most acute management crises is the significant dose-dependent decrease in arterial blood pressure.
It is. We routinely see a 25 to 40% systolic blood pressure reduction after a standard induction dose, often regardless of the patient's preoperative health.
What's the exact mechanism driving this profound hypotension? Is it just myocardial depression?
No. The primary mechanism is profound systemic vasodilation, which leads to a massive reduction in systemic vascular resistance, or SVR. This vasodilation is multifactorial.
How so?
It involves central sympathetic inhibition and a direct smooth muscle relaxation in the periphery, which is partially mediated by enhanced nitric oxide stimulation and attenuated calcium influx.
So we have a widened vascular bed, but we also see effects on the heart itself, correct?
Yes. Secondary to that vasodilation, we see a decrease in cardiac output and stroke volume, indicating a negative inotropic effect. And that is caused by a decreased intracellular calcium availability within the cardiac myocytes.
What about heart rate? This is a crucial comparative point.
Heart rate usually remains unchanged, or, worryingly, may even decrease, leading to profound, vagally mediated reflex bradycardia. This can be severe, especially since propofol markedly impairs the normal baroflex response to hypotension.
That's the danger. Unlike thiopentone, which usually elicits a compensatory tachycardia to maintain blood pressure, propofol removes that safety mechanism.
Precisely. The impaired baroflex response means the patient cannot compensate for the massive vasodilation, resulting in significant and sustained hypotension that requires immediate intervention.
Okay, moving to the respiratory system. Propofol is a known, profound depressant.
It is. Apnea is common, occurring in 25 to 35% of patients after an induction bolus.
And the duration of apnea is significantly increased when propofol is co-administered with opioids.
Yes, and propofol is not just a breath-holding agent. Even at subanesthetic doses, it depresses the ventilatory response to hypercarbia and hypoxia by acting on the carotid body chemoreceptors.
This is why non-anesthetists should never administer propofol for deep sedation.
Absolutely not.
However, there is a major airway advantage.
The advantage is twofold. Propofol induces bronchodilation, which is highly therapeutic in patients with reactive airway disease like asthma or COPD. Second, it significantly blunts laryngeal reflexes, providing superior conditions for placing supraglottic devices like the LMA or even tracheal intubation without needing muscle relaxants.
Often superior to the effect achieved with thiopentone.
Yes.
Let's discuss the cerebral effects, which are highly favorable and make it essential in neuroanesthesia.
Propofol demonstrates a beneficial coupled reduction in flow and metabolism. It significantly decreases the cerebral metabolic rate, the text CMR 0-2, by nearly half.
48 to 58%.
Right. And this metabolic reduction is tightly coupled with a decrease in cerebral blood flow, or CBF.
And since ICP is heavily dependent on CBF and cerebral volume, this translates directly to a reduction in intracranial pressure.
Correct. We see a significant decrease in intracranial pressure, or ICP, by 30 to 50%, making it a primary agent for managing acute intracranial hypertension.
And this flow metabolism coupling is also thought to provide neuroprotection during focal ischemia, right?
It does, by attenuating glutamate excitotoxicity, comparable to barbiturates. Crucially, propofol generally maintains cerebral pressure autoregulation and TEX-TO2 reactivity.
But the clinical caution is critical here. While reducing ICP is good, the drop in systemic blood pressure is the real threat in neurosurgical cases.
That's the most important clinical principle. The desirable drop in ICP, if coupled with the significant hypotension it causes, risks a critical reduction in cerebral perfusion pressure, or CPP.
Because CPP is calculated as MAP minus ICP. So if the MAP drops faster than the ICP, you jeopardize the brain.
Exactly. Thus, the mantra for neuro patients is support the MAP, then work about the ICP.
Finally, effects on other systems. We mentioned the colorful side effect earlier.
Indeed. Propofol does not adversely affect renal or hepatic function, a significant clinical plus. However, the excretion of its inactive phenolic metabolites can cause the patient's urine to turn green.
Which is a benign side effect that often alarms nurses and trainees.
It does. It also increases urate excretion, which can result in cloudy urine due to urate crystallization under certain conditions. Most importantly, unlike etomidate, propofol does not impair adrenocortical steroid synthesis, making it safe for long-term use.
The sheer versatility of propofol justifies its place as the benchmark 4 agent covering every setting of anesthetic care.
It does. For induction of general anesthesia, its rapid, smooth onset due to high lipid solubility and fast distribution remains unmatched.
And for maintenance of anesthesia, it's the agent of choice for TIVA, total intravenous anesthesia.
Yes, it's often combined with remifentanil, utilizing target-controlled infusion systems. Its rapid clearance and short CSHT allow for precise, easy titration of anesthetic depth and predictable emergence, making it the superior linear, continuous infusion agent.
The use extends widely into sedation, both in the high-acuity ICU environment and for procedural settings.
In the ICU, propofol is used for mechanically ventilated patients requiring deep, controllable sedation. Its added benefit is that it modulates postoperative hemodynamic responses, helping to decrease undesirable tachycardia and hypertension.
And for procedural sedation, like endoscopy or cardioversion,
The rapid onset and quick, clear recovery allow for efficient procedures and rapid patient discharge. It's ideal.
and it's the gold standard for daycare surgery, isn't it?
Absolutely. The high quality of recovery, fast emergence profile, and most importantly, its inherent anti-emetic properties significantly reduce the major postoperative morbidities, nausea and vomiting, which speeds up discharge time.
And finally, we revisit its essential use in neuroanesthesia.
It's an excellent choice for managing elevated ICP due to its coupled reduction of CBF and TEC-CMR023. But let us stress again, its use here is contingent on the clinician's ability to aggressively support systemic blood pressure.
Thereby maintaining CPP and ensuring adequate cerebral perfusion?
Yes. It also allows for earlier, more reliable neurological assessment post-procedure compared to agents with cumulative effects.
Dosing knowledge is not just about memorizing numbers, but understanding the crucial modifications required in vulnerable populations. This shows safety awareness.
It really does. So let's start with the standard doses. Induction is typically 1.5 to 2.5 milligrams per kilogram as an IV bolus.
And for maintenance TIVA, the usual infusion range is 4 to 12 milligrams per kilogram per hour.
For ICU sedation, we generally use a much lower range, usually 0.3 to 4 milligrams per kilograms per hour. However, it is the adherence to the low end of this range that is critical, as high doses, especially when prolonged, carry the profound, life-threatening risk of propofol infusion syndrome.
We'll get to PIS in detail shortly, but first, a vital dosing principle, especially in obese patients, is the weight basis.
Yes, propofol dosing should generally be based on ideal body weight, IBW, not actual body weight, ABW. This is because of its highly lipophilic nature.
If you dose based on ABW in obese patients, you'll give a massive overdose relative to the central compartment.
And you will see predictable and severe hypotension.
Now, for the crucial dose modifications, these are classic exam scenario questions. Let's focus on the elderly and the hemodynamically compromised.
Elderly patients require a significantly smaller induction dose, often starting at 1 milligram per kilogram or even less. The reason is twofold.
Okay.
They have a reduced central volume of distribution and an increased intrinsic sensitivity to the drug's effects, resulting in higher peak plasma concentrations for the same administered dose.
Failing to reduce the dose in the elderly almost guarantees severe, unnecessary hypotension.
It also guarantees it.
And the most challenging group, cardiac patients or those with hypovolemia.
In these high-risk patients, the profound vasodilation and myocardial depression induced by propofol are exceptionally poorly tolerated, especially when the baroreflex is impaired. The hypotension can quickly lead to shock or cardiac arrest.
How do we manage this in the OR?
Loading doses are often avoided entirely. Administration requires extremely cautious, slow titration. We call it start slow and go slow.
Yeah.
You have to be proactive.
So placing the patient on a vasopressor infusion, like norepinephrine or phenylephrine, before induction.
Yes, and aggressively ensuring adequate volume resuscitation to maintain MAP and, critically, maintain cerebral perfusion pressure. The dose must be minimized, often staying in the low sedation range of 25 to 75 milligrams per kilogram per minute when used for head injury patients.
Okay, let's transition to summarizing the major advantages that have established propofol as the benchmark.
Let's do it.
Number one is clearly the pharmacokinetic profile, rapid onset and recovery.
Yes. High lipid solubility combined with high metabolic clearance provides that short, predictable, context-sensitive half-time. This is the hallmark of a TVA agent.
Advantage 2 is the powerful and unique anti-emetic property. This is an active pharmacological effect, not just a benign side effect. You must detail the mechanism in the exam.
Right. The anti-emetic effect is effective even at subhypnotic doses, like a 10 to 15 milligram IV bolus or a very low infusion rate, making it a treatment for established PO&V.
And the mechanism is multifaceted, isn't it?
It involves 4 key CNS sites. Reduced release of glutamate and aspartate in the olfactory cortex, direct inhibition of the chemoreceptor trigger zone, or CTZ, inhibition of vagal nuclei, and a reduction in serotonin levels in the area postrema.
Which makes it effective for non-vagal PO&V and sometimes chemotherapy-induced vomiting.
It does.
Third is the favorable neurophysiological profile, combining cerebral protection with anticonvulsant and antipruritic activity.
The reduction in TEC CMR-OT2, CBF, and ICP provides that cerebral protection. It is a potent anticonvulsant and is often the agent of choice for treating status epilepticus that is refractory to first-line agents.
And the overall induction and emergence are smooth, with a low incidence of reactive airway disease.
And we get excellent conditions for airway instrumentation because of the profound depression of laryngeal reflexes. These advantages combine to create a uniquely safe and versatile drug.
Okay. This next section, particularly propofol infusion syndrome, is where the most advanced level of understanding is demanded by the examiner. Let's talk adverse effects.
We start with the certain consequences of a bolus. Cardiovascular depression, that profound hypotension due to SVR reduction and impaired baroreflex, and respiratory depression apnea. Both require immediate monitoring and management by qualified personnel.
Next, the nuisance factor that is the most common adverse event. Pain on injection.
We must reinforce the prevention techniques. Always use a large vein and use lidocaine pretreatment. Students often forget to mention the time constraint for mixing lidocaine.
It must be used immediately to prevent emulsion destabilization and coalescence.
Exactly. And remember, the use of specialized 2% formulations containing medium-chain triglycerides also helps mitigate this pain.
The risks directly tied to the lipid formulation also include hypertriglyceridemia and risk of infection.
Right. Prolonged infusions in the ICU mean the patient is receiving significant nutritional support via the emulsion about 1 kcal per ml. This lipid load can lead to hypertriglyceridemia.
So routine monitoring of serum triglyceride concentrations is mandatory after 48 hours of continuous infusion.
Yes, to prevent pancreatitis and other complications. Furthermore, the risk of infection remains extremely high due to the lipid vehicle being a potent bacterial culture medium. We must reiterate, for the sake of the exam and for patient safety, strict adherence to aseptic technique is mandatory, and the 6-hour discard rule for an open vial is non-negotiable.
Let's go into the necessary detail on propofol infusion syndrome, or PIS. This is a rare, life-threatening metabolic catastrophe that results from high-dose, prolonged exposure.
PIS is strongly associated with high-dose regimens, typically greater than or equal to 4 milligrams per kilogram per hour, and prolonged duration, often 48 hours or more.
And what are the key risk factors the examiner will look for?
Young children, patients with underlying mitochondrial disease or genetic defects in fatty acid metabolism, and those receiving inadequate carbohydrate intake or excessive exogenous lipid overload.
What is the complex pathophysiology that underlies this catastrophic event?
The prevailing theory centers on propofol's interference with mitochondrial function. Specifically, it is thought to impair fatty acid oxidation at the level of the mitochondrial transport system.
And when this essential metabolic pathway is blocked, the mitochondria shift into an anaerobic state,
Leading to the uncoupling of oxidative phosphorylation. This results in poor ATP generation and cellular energy failure, which manifests as systemic dysfunction.
and the clinical features, the triad, are horrifying.
They are a cascade of system failures. The syndrome is defined by refractory bradycardia, leading potentially to a systole. This is often the sentinel sign.
So the heart rate just drops and doesn't respond.
It progresses rapidly to severe metabolic acidosis, which you'll see as a high anion gap and high lactate on an ABG, and widespread muscle breakdown leading to rhabdomyolysis with extremely high creatinine kinase or CK levels.
Other features include hypertriglyceridemia, acute kidney injury, and acute fatty liver infiltration.
It's a total collapse.
Therefore, prevention is paramount, as treatment is often supportive and reactive.
Prevention means absolute vigilance. Strict adherence to infusion limits, ideally keeping the dose below 4 milligrams per kilogram per hour in at-risk groups, providing early and adequate carbohydrate supply to shift the energy substrate away from fatty acids.
And aggressive monitoring. Triglycerides, ABG for metabolic acidosis, and CK.
Yes. If PIS is suspected, the treatment is non-negotiable. Immediate cessation of propofol is mandatory, followed by full supportive care, hemodynamic maintenance, and, in severe cases, the use of ECMO to stabilize the patient.
Finally, we must note the other CNS effects.
We do see excitatory phenomena, especially during induction or emergence. Myoclonus, opisthotonus, spontaneous movement, hiccuping. And while propofol is generally anticonvulsant, there's a small risk of paradoxical proconvulsant action, requiring caution in poorly controlled epilepsy.
Defining the limits of propofol use is the sign of a safe and judicious practitioner. Let's clarify the absolute contraindications.
The only absolute contraindication is a documented allergy to propofol itself or its components. While we discussed the low risk of egg yolk allergy, severe specific allergies to the emulsifier remain an absolute contraindication.
What about relative contraindications?
These heavily focus on the patient's circulatory status, severe hypovolemia, uncorrected hemodynamic instability, and severe cardiac compromise, where the profound hypotensive risk outweighs the benefits. Poorly controlled epilepsy also remains a relative caution.
Let's discuss use in specific patient populations, starting with neurosurgery and head injury.
We have to reinforce the warning here. In neurosurgery, the use of propofol, while beneficial for reducing ICP, must be managed with extreme vigilance regarding systemic blood pressure.
Because if MAP isn't supported aggressively, the reduction in CPP can cause secondary brain injury.
Exactly. Infusions are generally restricted to low, mild to moderate sedation doses, ensuring CPP safety.
We also have the FDA warning regarding pediatric and obstetric use.
Yes, the FDA has issued a warning regarding potential neurotoxicity in the developing fetal brain, based on animal studies showing neuronal death after prolonged exposure. While the clinical relevance in humans is still debated, the principle holds.
The exposure of the developing fetal or neonatal brain to general anesthetics, including propofol, should be minimized when clinically possible during pregnancy and in infancy.
That's the safe approach.
Finally, the clinical reality of drug interactions. This is frequently tested because it impacts dosing decisions in the OR.
Propofol is highly synergistic with opioids like remifentanil and alfentanil and benzodiazepines like midazolam. This synergism means less propofol is required for adequate anesthesia.
What?
But this combination also significantly increases the risk and duration of ventilatory depression.
I recall the source mentioning a specific dose adjustment for midazolam.
That's a high-yield detail.
Mm-hmm.
The combination with midazolam can increase blood propofol concentrations by approximately 25% by reducing its metabolic clearance.
So if you pre-medicate heavily with midazolam, you must reduce your calculated induction dose of propofol by at least a quarter.
Or you risk profound hypotension and respiratory overshoot.
And the interaction with regional anesthesia?
Interestingly, regional techniques also reduce propofol requirements. For instance, a high epidural blockade with ropivacaine can reduce the propofol dose required for maintenance by about 30%.
And why is that?
It's hypothesized to be due to the sympathetic block causing a reduction in hepatic and/or renal blood flow, thereby lowering propofol's clearance and increasing its effective concentration.
A truly excellent long answer includes a structured comparative analysis. Let's focus on the two main competitors, propofol displaced.
Let's do it.
We start with the classic comparison, propofol versus thiopentone, the barbiturate we rely on less today.
The primary differentiation is in the recovery profile. Propofol offers fast, clear-headed recovery due to its exceptionally high clearance and short CSHT. Thiopentone is cumulative. It exhibits zero-order kinetics with repeated administration, leading to a much slower recovery and a long, unpleasant hangover. Thiopentone's clearance is dramatically lower than Propofol's.
And the airway response is fundamentally different.
Propofol is advantageous. It causes bronchodilation and profoundly blunts laryngeal reflexes, offering smooth conditions for LMA placement. Thiopentone, a barbiturate, carries a recognized risk of bronchospasm, or laryngospasm, and preserves laryngeal reflexes to a greater extent,
Which can sometimes complicate airway management. What about the adverse profile?
Propofol's main vascular issue is pain on injection. Thiopentone carries the potentially limb-threatening risk of tissue damage with extravasation or, critically, arterial spasm and thrombosis with accidental intra-arterial injection.
And thiopentone is also absolutely contraindicated in acute intermittent porphyria, whereas propofol is considered safe.
Correct.
Next, propofol versus etomidate. This comparison often centers on hemodynamics versus the endocrine system.
Etomidate's primary undisputed advantage is hemodynamic stability. It maintains MAP and CPP exceptionally well, causing minimal myocardial depression or vasodilation,
making it the classic induction agent for trauma or septic shock, where hemodynamic stability is the priority.
Absolutely. Propofol, as we know, causes profound cardiovascular depression.
But etomidate has that major fatal flaw, particularly concerning prolonged use.
That flaw is the endocrine effect. Etomidate inhibits the synthesis of adrenocortical steroids, cortisol, and aldosterone by reversibly blocking 11-beta hydroxylase, even at subanesthetic doses.
Whereas propofol does not impair this synthesis and is safe. This absolute contraindication for prolonged use means etomidate cannot compete with propofol in the ICU sedation setting.
Not at all.
And on the CNS front.
Etomidate is associated with a high incidence of myoclonus, those spontaneous involuntary muscle movements, and can even cause seizures in predisposed patients. Propofol is typically anticonvulsant.
Finally, the historical formulation issues.
Etomidate was historically formulated in 35% propylene glycol, which caused severe pain on injection and thrombophlebitis. While the newer lipid formulation, etomidate Lipuro, has improved vascular compatibility, Propofol's lipid emulsion remains the default standard for continuous infusion due to its non-cumulative PK profile.
Okay, let's consolidate the critical rapid recall information. This is your mental checklist for passing the Viva.
Let's do it.
So what are the frequently asked Viva questions designed to test core instant recall?
1. Why is propofol elimination faster than its long elimination half-life suggests? The integrated answer is high clearance rate, exceeding hepatic flow, and rapid redistribution out of the central compartment.
Okay. 2.
Name all 4 components of the standard propofol emulsion.
Right.
Propofol, soybean oil, glycerol, and purified egg phosphatide.
3. How does propofol cause green urine?
Excretion of phenolic metabolites.
And 4. What is the key difference between propofol and phosphopropofol?
Fospropofol is a water-soluble prodrug, avoiding the lipid vehicle risks, but requires enzymatic hydrolysis by alkaline phosphatases for activation, leading to a slower onset.
Okay, and what are the classic high-stakes mistakes students make that immediately cost them marks?
Trap 1. The allergy misstatement. Confusing the risk of egg allergy. You must know that Propofol's emulsifier is from the yolk, lecithin, not the white, albumin. Do not state that propofol is absolutely contraindicated simply due to a general egg allergy history.
Trap 2. Forgetting the time limit. Failure to mention the time limit for an open vial, you must state the absolute deadline, 6 hours. This is a red flag for unsafe practice.
Trap 3. Ignoring CPP. Not linking the potential hypotension risk directly to the most dangerous outcome in neurosurgical patients. The risk is not just low blood pressure, it's the critical reduction in cerebral perfusion pressure if the MAP is not diligently supported.
Therefore, the safe examiner-approved answers must stress 3 areas: proactive management of hemodynamics, strict aseptic technique, and monitoring for PIS.
Yes, triglycerides, ABG, and CK.
For a 20-mark long answer, presentation is crucial. A well-placed, quickly sketched diagram elevates the score from average to excellent.
It really does.
What diagrams should the learner be prepared to sketch?
2 diagrams are highly useful. First, sketching the structure of propofol, the 2006 D-isopropylphenol structure. Second, and the single most impressive diagram, is the context-sensitive halftime curve.
Okay, what does that look like?
You should sketch 2 lines. The propofol curve, which remains relatively flat and low even after several hours of infusion, contrasting sharply with the thiopentone curve, which rises steeply, demonstrating its cumulative nature. This visually proves your understanding of its superior PK profile.
Structure is key for maximizing marks. How should a student organize that comprehensive 20-mark answer?
Use clear, bold, labeled headings. The structure we follow today is ideal and, frankly, mandatory. Start with chemistry formulation, then mechanism of action.
And the core of the answer.
The core must be detailed, segregated into pharmacokinetics, especially CSHT, pharmacodynamics for cardio, resp, and neuro, clinical uses, and a dedicated detailed section on propofol infusion syndrome, which must cover risk factors, pathophysiology, and management.
Clear segregation ensures the examiner quickly finds all the high-yield information and understands that you have organized your knowledge clinically and academically.
To wrap up, let's condense this deep dive into the top 10 high-yield bullet points for your final review before the exam.
1. Chemical identity. It's a substituted alkylphenol, 2006 D-isopropylphenol, and it's non-chiral.
2. Formulation risk. Lipid emulsion, which means the 6-hour discard rule and strict aseptic technique, are mandatory.
3. A mechanism of action. Highly selective GABA-beta subunit agonism, increasing chloride channel duration.
4. Metabolism uniqueness. Clearance is exceptionally high, exceeding hepatic blood flow due to significant extra-hepatic metabolism in the lungs and kidneys.
5. Recovery profile. CSHT is short and predictable, leading to rapid, clear-headed emergence.
6. Major hemodynamic risk. Profound hypotension due to significant SVR reduction and impaired buroflex compensation.
7. Respiratory profile. High risk of dose-dependent apnea, but offset by the clinical advantage of bronchodilation.
8. Neuroadvantage. Reduces text CMR022, CVF, and ICP, but the priority in neuro cases is always to maintain CPP.
9. Anti-emetic power. Active anti-emetic properties, effective at subhypnotic doses, acting via multiple CNS sites.
And 10. PIS sentinel. Propofol infusion syndrome is a risk with high-dose prolonged infusions, so there's a 4 mg per kilogram per hour limit. And it's characterized by refractory bradycardia, severe metabolic acidosis, and rhabdomyolysis.
Excellent.
Finally, practicing a polished conclusion is essential for the 20-mark answer. Here is a model conclusion. Propofol remains the undisputed benchmark intravenous anesthetic due to its uniquely favorable pharmacokinetic profile, allowing rapid and predictable emergence across diverse clinical settings, including daycare and complex neuroanesthesia.
But there's a however.
However, its widespread use demands diligent titration, meticulous adherence to aseptic technique, and hypervigilance for the rare but potentially fatal propofol infusion syndrome, thereby ensuring the drug's significant benefits are realized safely and predictably in all patient populations.
That brings us to the end of this essential deep dive. For you, the learner, my final thought is to always seek the integrated knowledge. Don't just memorize the effects, understand the why, connecting the fundamental property of high lipid solubility to both the rapid distribution, the extrahepatic clearance, and the inevitable risk of profound vasodilation is what turns raw data into clinical wisdom.
And that wisdom allows us to anticipate the future. A provocative question for you to mull over as you study. If new water-soluble prodrugs like phos-propofol can fundamentally eliminate the lipid-related risks, the infection, the hypertriglyceridemia, and the PIS risk, would propofol then become the undisputed absolute gold standard for all prolonged ICU sedation, effectively retiring etomidate forever, regardless of etomidate's superior hemodynamic stability during induction? That's the challenge ahead for our specialty.